Dr. Chatterjee, we can start?
Yes, sir.
Yeah. Good morning. We have all third year PGTs, some are online. We have some MS PGTs also who are in MR Bangun now. So we'll start with Nitish here. And then one to the other, I'll just call out the name, they will join. Deepank, you're audible?
Yes, sir.
Yeah. So we will have some OSCE scenario from trauma management. So I'll just pick up one of you and then you keep answering. Madam has all the answers, but you just try to answer the scenario. And then if you cannot answer, Madam will keep on answering. So the first scenario will be answered by Dr. Nitesh Pradhan. Nitesh, yeah. So Nitesh is here. So Madam, you can start. Madam is Professor Shobita Chatterjee, who has special interest on trauma. She is ATLS instructor and professor of surgery at IPGM SKM Hospital. And we will have a number of PGTs who will be joining us in different questions. So Dr. Chatterjee, you can start.
Okay. Good morning, sir. Good morning, dear students. We will start off the session. Sir has requested me to conduct this session on trauma management in an OSCE pattern. So I have created 5 or 6 scenarios in the pattern of an OSCE where we will expect you to respond. But yes, as sir said, don't worry. If you get stuck, we will carry the discussion on to the other candidates. And finally, sir and myself will try to help you out with the answers. So yes, Nitesh. Yeah.
Yes,
good morning, Nitesh. Right.
Good morning, ma'am.
This is the first scenario, Nitesh. It's a 34-year-old non-helmeted male brought to the ED following a head-on collision with a stationary truck. Patient is unconscious. The parameters are given. Pulse is 110, BP 100/60. SpO2 is 94% with NRBM mass. Respiratory rate is 20. The GCS is E1 M3 V1 on arrival in the ED. There is a laceration over the scalp which is bleeding. An initial assessment has been done and resuscitation has been started and a CT brain was done. I am not going into the initial assessment because we've had repeated discussions on this in our previous classes. So I'm directly moving on to this, that a CT brain was done after initial assessment and stabilization of the patient. Now, Nitish, have you had a good look at the vitals?
Yes, ma'am.
Okay, fine. So this is your CT, right? Please do take a good look at it.
Yes, ma'am.
Fine? Okay. So what is your diagnosis based on this CT?
Ma'am, based on the diagnosis, ma'am, this is a case of extradural hematoma.
Okay, why do you say it is an extradural hematoma?
Ma'am, there's a ma'am biconvex.
What? How do you describe density?
Sir, hyperdense.
Yes, go ahead.
Area of hyperdensity.
Hyperdensity area.
What do you think is the area like? So if you take this axial cut, what this area is likely to be?
Sir, it is a temporal region, sir.
Parieto-temporal.
Parieto-temporal region.
Okay.
Okay, but Nitish, just a one-word answer will not be sufficient because you might have more marks on this OSCE.
You see, there is another area of black area that is likely to be the lateral ventricle.
Yes, sir.
So what do you feel?
Sir, first, sir, there is a midline shift.
Yes.
And sir.
So whenever you have a CT,
the
ipsilateral ventricle is, sir.
That is not seen, effaced. You see,
yes, sir.
On this side, the lateral ventricle is not seen, is effaced. And
midline shift.
So Nitish, see, if you get a CT, yes, your answer is correct that it is an extradural hematoma, but you have to be a little more elaborate. Start looking from outside. There is
a scalp hematoma
in the subgaleal region.
Yes, sir. Yes,
bony tablet seems to be intact, no fracture.
Yes,
as you correctly said, there is an extradural hematoma as seen by the hypotenuse lesion in the, which is biconvex in nature. Then you move in, you see that the ventricle on this side has been effaced with haziness in the brain cuts, which will mean what? That there is again diffuse axonal injury in the rest of it. The midline here has been shifted and the right ventricle is also visible. So just don't say EDH, give all the points that are. So this is classically a picture of an EDH. Now, what injury within the brain will lead to this classical CT presentation? What injury within the brain will lead to a classical look like this? So it must be bleeding from somewhere to give rise to this. But what is
yes, ma'am, it rises from
temporal
mostly from the middle meningeal artery, ma'am.
So it is a bleed from the, it is an injury to the middle meningeal artery, which is leading to this bleeding. Now, any patient of head injury that comes to your ED, do you routinely do a CT brain for all of them, or are there specific indications of CT brain following head trauma?
There is a specific indication according to NICE guideline, ma'am.
Okay, so what are the, can you tell me 4 or 5 indications where you will do a CT brain?
Ma'am, if patient, ma'am, GCS, we'll see the GCS, ma'am, if GCS is less than 13.
Less than 13. What about 14 and 15? Do any patient of GCS 14?
Ma'am, for 14 and 15, we'll observe the patient for around 2 hours. If the GCS will subsequently decreased, then we'll go for CT scan.
Okay. So not subsequently decrease, you observe for 2 hours. If you see that there is no improvement in the GCS.
Yes, ma'am.
If there is no improvement in the GCS, then you might need a CT scan. Otherwise, yes, you're right that it is below 13. What else?
Ma'am, if there's a history of vomiting, seizure, and loss of consciousness, ma'am.
Okay. Anything else?
Ma'am, then age, ma'am. If patient is pediatric, the pediatric or the advanced stage, ma'am.
So why do we need a special requisite for CT scan for these patients, the elderly patients or the pediatric patients?
Because in elderly patient, ma'am, the first brain there will be a cortical atrophy and the vessels are become fragile. So, ma'am, they are more prone to
trivial trauma. Trivial trauma even can cause a bleed.
So because of the brain atrophy, there is a greater space between the vault and the brain, and the extradural veins which bridge this area are very easily injured in spite of trivial trauma. So he may just, the candidate might just hit his head against the wall and might have an extradural hematoma. So yes, you're right. Anything else?
Yes, ma'am. If patient had depressed skull fracture, then.
So I'll summarize it for you. So these are the indications of CT scan following head injury. If the GCS is below 15, even 2 hours after injury, any evidence of neurological deficit, open skull fracture, signs of basal skull fracture. So what are the signs of basal skull fracture, Nitish?
Anterior fossa, middle fossa.
So
anterior fossa, there will be a
black eye.
Black eye. Then, ma'am.
Also called a raccoon eye.
Raccoon eye.
Right? Raccoon eye. What else? What about middle?
CSF leak from.
Okay. Any other bruising which might attract
bruising, then a battle sign.
Battle sign. So yes, you may have a raccoon sign, you have a battle sign, you may have CSF rhinorrhea, CSF otorrhea,
yes,
and bleeding from the ear or nose, right? But bleeding from the ear and nose, you have to be cautious because they may also be due to local trauma. So yes, moving on to the next point, vomiting, you had said, extremes of age, you have said, retrograde amnesia and severe headache. Though the patient may be totally oriented 15 by 15, but she is complaining of persistent severe headache, that is a place where you might have to move in and do a CT scan. Okay. So what is your primary goal? You are going to treat this patient. What is your goal of treatment? Patient is unconscious, I think E1, M3, V1. What is your primary goal of treatment?
First patient to be intubated as GCS is less than 7.
Okay. So it's a severe head injury, you want to intubate. I agree with you. My question is, what is the goal of your treatment?
So ma'am, we have to decompress the
It should be mentioned, should be early decompression.
Yes.
Because you see, it is the gross midline shift.
Yes.
Okay.
Yes.
The goal should be early decompression.
But the point is that the patient already has a brain injury. That is a primary brain injury, which has already happened. You cannot alter the brain. What further physiological changes have to be retarded so that there is no further brain injury? That is going to be the primary goal. Your decompression is done with the intent to prevent further physiological deterioration. So what is that goal?
Yes, ma'am.
Your goal will be to avoid hypotension and hypoxia. These are the two words we want to hear. Your goal of treatment is to avoid hypotension and hypoxia. With the intent of avoiding hypoxia, you are intubating the patient so that the airway is kept patent and the patient's oxygen saturation is maintained. With IV fluid, you are avoiding hypotension, because if there is hypoxia and hypotension, there is going to be secondary brain injury. The primary brain injury has already occurred due to the assault. The secondary brain injury is something that the physician has to prevent. Now, once these are the primary goals. And the next is, as sir said, that you have to obviously consider decompressive craniotomy in this patient, because as you see that number one, there is a huge EDH, and number two, and more importantly, that there has been a midline shift. So when we ask for primary goal, we want to hear two words from you, that prevent hypotension and hypoxia. Okay?
Yes.
Now coming to this next question, what is your plan of management? This is exactly what we have just discussed, that initial resuscitation with prevention of hypoxia and hypotension, and then a surgical decompression, which will, take care of this midline shift.
Yes, ma'am.
Right? Now, prior to, suppose you're working in a center where you do not have emergency neurosurgical facility. Now, is there any options of pharmacological management, any medications that you might use in your management of this patient?
Ma'am, we will decrease, will try to decrease the edema by giving mannitol.
Okay.
Or any diuretics.
Is he giving mannitol to all patients?
No, ma'am.
Okay, so which patients will you give mannitol, which will you not give mannitol? Since you talked about mannitol.
Patient
with this patient, he has an EDH. Will you give mannitol? Will you not give mannitol? Yes or no?
And we'll give mannitol for this patient.
Okay. So if you give mannitol, what might happen subsequently?
Mannitol will cause brain shrinkage. So
the space is going to increase more, right?
Yes, ma'am.
So there is going to be more space for the blood to collect. So there is going to be further bleeding.
Yes, ma'am.
So in a case of EDH, we generally do not give mannitol, except in situations where you're suspecting brain herniation, uncal herniation. Okay? But yes, in a subdural hematoma, you can give mannitol. So a mannitol is a good thing in your armamentarium, but you have to be very judicious as to which patient you're going to give, which you are not going to give. If you haven't had a CT scan done, please do not start mannitol, because you have no way of knowing whether the patient has an ETH or not. Okay? So mannitol is only to be given when you're suspecting a herniation. Moreover, avoid if the patient is hypotensive already, because head injury may not be isolated. Patient may be in shock for many other, a polytrauma patient might come in shock also. So if the patient is in hypotension, do not give mannitol. Okay? So EDH, no mannitol. Hypotension, no mannitol. EDH, mannitol to be given only if you're suspecting an uncal herniation. Any other medication?
We'll start anti-epileptic, ma'am.
Will you again start anti-epileptic in all patients? So again, anti-epileptics to be given if the patient is having a seizure, not blanket to all patients, okay? Because anti-epileptic is what? You have an excited brain which you want to cool down. Even if the patient is not seizing and you give an anti-epileptic, you are going to depress the patient and you will not be able to assess the neurological, whether he is improving or deteriorating, okay? So not all patients, if the patient is having seizures, then you will give anticonvulsants. Anything else?
And another indication would be if there is evidence of brain laceration in CT. In that case, you can give prophylactic anti-epileptic. If there is evidence of brain laceration in CT scan.
Okay, sir. But brain laceration, will it be appreciated on primary CT, sir? It's usually not so well appreciated. It's a delayed CT where, once the edema and everything has settled down, that the laceration can be. Okay, and we are moreover doing obviously a non-contrast CT in case of head trauma. So laceration.
Mostly it's a therapeutic anticonvulsant.
Yeah, so it comes later. So this is the fresh patient who has arrived at your ED that we are discussing. Any other medication, any other pharmacological management that you might think of? So yes, you might use mannitol. We've discussed that. If mannitol is not available, the same thing can be, same purpose can be served by hypertonic saline or even furosemide. Anticonvulsants, we've said only if the patient seizes. Sedation may be needed, particularly some of the patients are very combative. They're very agitated. You need to send the patient for a CT scan. You're not being able to do so. You might sedate, but you have to remember they all have to be short-acting sedations so that you can assess the GCS, sedate the patient, get the CT scan done, and meanwhile, while the effect of the sedative is going down, you might again be able to assess. If you give a long-term sedative, long-acting sedative, again, the response of the patient or the improvement or deterioration of the patient cannot be assessed. And last is paralytics. Again, certain patients need to be paralyzed if they're very combative. If the patient has been intubated, you need to attach him to a ventilator. You need to paralyze the patient. So this is the list of pharmacology of management that you
Dr. Chatterjee, you're not audible. We can't hear you, Dr. Chatterjee.
Am I audible, sir? Sorry, I got locked out. Right, sir. Sorry, sir, I got locked out. So
Good.
whatever you give as medications, you have to keep few things in mind, that you have to prevent hypotension. You have to see that neurological evaluation can be done in between the drugs, because their prolonged sedation or paralysis may hamper your interpretation of the patient's progress through the trinium. Okay. Okay, let me just make it full screen. Okay, so any questions from the first scenario before we move on to the scenario? Next scenario.
You said decompression. How is EDH decompressed? Have you seen a EDH being operated?
Posting has been one.
Okay, so what should be the mode of decompression? What is usually done?
Sir, initially, sir, if like per hole, you can.
You see, such a large hematoma may not be only decompressed with a bar hole.
Yes, sir.
Okay.
Yes.
So bar hole is a first point that you made a bar hole and then you convert these to what?
Sir, decompressive craniotomy.
Two things. Either it can be, if it's a large hematoma, they can plan that they will raise a bone flap.
Yes.
Okay. So make multiple bar holes and then take that bone out as a flap and don't discard it. This flap
How can you preserve this bone that sir just asked you to take out?
Yeah. Subsequently, this bone flap may be replaced. So what are the ways that you can keep this bone flap? One is you can defreeze it. You can put it in a deep freezer, and then one is feet to be reimplanted. You can just take off, thaw it, and then otherwise there are ways that you can place it in the abdominal wall. You can place the bone in the raise the skin flap and put this bone inside in the subcutaneous plane and close the skin.
So the purpose of this is that it is remaining in the normal tissue environment, and it is also getting its blood supply from the surrounding tissues. And later date, when the patient has settled and improved, you can take out this flap and put it back. The primary idea of raising this flap and removing the bone is because the brain is already edematous, and subsequent to the decompressive craniotomy also, there may be further edema of the brain. So if there is an area which is devoid of the skull bone, the edematous brain can pout out, and then once the edema subsides, it can shrink back. Now, if the bone was there, that there would be no space for the edematous brain to pout out. That would cause, again, further injury to the brain.
And second is, if it's not a large hematoma, you can do a bar hole and extend this bar hole as a craniectomy. That means you can enlarge this bar hole. And once you drain the hematoma, you do a lavage, you see there is not much of bleeding now. What you do with the dura mater? Because here dura is stripped inward. The dura is stripped inward. You have drained the blood.
We have to hitch the dura with the
so circumferentially around this craniectomy, you place suture in the dura and suture it to the pericranial tissue. This is known as dural hitch stitch. It's a dural hitch stitch because this will prevent further collection of blood in the extradural space. I think for OSCE is a very nice OSCE discussion. So these are the usual thing one should come. You may have a CT scan plate and then you discuss this part of this OSCE.
So shall we move to the next question and the next candidate, please?
Yes.
Who is the next candidate?
I believe he's in the way.
Good morning, sir. Good morning, sir.
Milind,
good morning,
you can take the next question.
Yes, sir. Yes, sir. Good morning, sir. Good morning,
Good morning, Milind. Milind, your patient is a 22-year-old male. He is in distress after a fight in a bar. He has been stabbed on his back, and the stab wound is in the 5th intercostal space on the left side towards the back. His pulse is 120, PP is 80/60, respiratory rate is 32, and SpO2 on arrival in the ED is 88.
Yes, ma'am.
Okay, clear about the situation?
Yes,
okay.
Yes,
so a chest X-ray was done after the initial resuscitation. A chest X-ray was done as part of primary assessment. Look at the chest X-ray. This is a real patient we have in our ward admitted at this moment. So what do you see? What is your diagnosis based on this chest X-ray?
Ma'am, based on the chest X-ray, I feel that the patient has a left-sided hemothorax.
Left-sided?
Hemothorax, ma'am.
How? Mild, moderate?
Severe, sir, severe. Because the entire, most of the left lung has appears, sir, to be involved, sir.
So
is there associated pneumothorax? Is there associated pneumothorax?
See, in a trauma scenario, remember, isolated hemo or pneumo is unlikely, particularly when we are saying that there is a stab wound. So there may always be an associated pneumothorax, but usually if there is a clear-cut pneumothorax, you might get an air fluid level sort of an appearance here, which is not. And
Okay.
moreover, the little bit of lung that you can see the bronchovascular markings going up to the periphery.
Yes, ma'am.
Yes, sir? Yes. So
Yes,
in this case, even if there is the pneumo is not the dominant thing, it is basically a massive hemothorax.
Hemothorax.
Right.
Is there a
Yes,
mediastinal shift? Can you appreciate mediastinal shift in this patient?
It's in the upper part, sir, slight mediastinal shift, right, near the clavicle, the clavicle area, sir. I can see that.
Can you see my
right.
cursor, Milind? Can you see the cursor?
Yes, ma'am.
This is the
Yes, ma'am.
trachea, right? And
Yes,
this is the right bronchus. This is the
Yes, ma'am.
trachea. This is the right bronchus. Now,
Yes, ma'am.
there is a slight, it appears, but mind you, the position of the patient also is going to give you a clue. Now, if you see the position of the patient is slightly tilted towards the right, because a trauma
Yes, ma'am.
patient, you always do not expect them to lie straight.
Straight,
So
yes, ma'am.
even if there is a shift, it is a very mild shift, and the right bronchus is always a continuation of the trachea. So do not judge by the position of the bronchus, judge by the position of the
Position
trachea.
of the trachea. Yes, ma'am.
Now, with such a large hemothorax, as you said, do you expect a mediastinal shift?
Yes, ma'am, I would expect.
Yes, I think that is the reason why sir asked you that question. With such a patient, you may expect a mediastinal shift, but in our patient, we didn't have a very significant mediastinal shift. Now, other than a massive hemothorax that you said, what other life-threatening condition would you like to rule out in this patient? As far
Ma'am,
as the thorax is concerned, nothing else. I'm not talking about other injuries.
okay. Ma'am, as far as the thorax is concerned, ma'am, since it is such a massive hemothorax, I would like to rule pneumothorax also accompanying.
Okay.
I would
Agreed.
like to rule any injury to the pericardial tissue, any pericardiac tamponade. I would like to rule out any diaphragmatic injury.
Okay. I'm talking about, hold on, Milind, very specific.
Yes.
Life-threatening. There can be multiple injuries. Life-threatening mentioned the two things that you answered first is pneumothorax, a tension pneumothorax particularly.
Tension pneumothorax and pericardiac effusion.
But again, look at this patient. He has a stab wound in the back. Is it likely that he will have a tension pneumothorax with a stab wound?
No, ma'am.
Less likely. Because there is no clear black and white in trauma. Less likely.
Yes,
because if it is a very small point stab, sometimes the tissue above tends to fall back. And then it might give rise to it. But you have to keep in mind such a large hemothorax may be associated. Now, if you were to consider the two diagnoses that you gave of a tension pneumothorax and pericardial tamponade, what clinical finding will guide you towards this other than auscultation of the chest?
Ma'am, clinical finding, ma'am, for percussion over the
trauma patient percussion, very difficult to do. Noisy ED, you may not appreciate. Anything very, very characteristic, which you'll just pick up the moment you see the patient. An inspectory finding for that matter.
JVP.
Inspector finding. JVP, ma'am.
Yes, pardon?
Ma'am, raised JVP in case of pericardiac tamponade.
Pericardial tamponade and tension pneumothorax will give you a raised neck vein, a raised jugular vein. Now, in a massive hemothorax, can you get, see, raised JVP is why? Because the mediastinum is getting compressed, even with be it a tension or a pericardial tamponade. Now, a massive hemothorax should also give you a raised JVP by the same logic, isn't it?
Yes, ma'am, because it will apply pressure.
Yes, but do we get raised JVP in a massive hemothorax?
No, ma'am.
Why not?
Ma'am, because there is systemic loss of systemic loss of blood, ma'am. There is anyway systemic loss of blood, and which is being collected in the thoracic cavity, and there is hypotension.
So the one simple answer is because the patient is hypotensive because of massive blood loss, his neck vein will not get engorged. Simple answer. So, you know, by the etiological cause, it should cause a distended neck vein. But in a hemothorax, massive hemothorax, we do not get it because the patient is in
Hypotension.
hypovolemic shock.
Okay.
Okay, hypotension. Okay. So you have to rule out about, you had mentioned diaphragmatic hernia, diaphragmatic injury rather. That is not an immediate life-threatening, mind you. That's a potentially life-threatening. Okay, you can have an esophageal injury. You can have
Immediate
bronchial
life-threatening.
injuries. So they are all potential life-threatening, but immediate
Yes,
life-threatening is only these two. That is a tension and a
Yes,
catheter. Okay, fine.
Correct.
So what will be your next step in the management of this patient?
Ma'am, if the patient is stable, I would like to put a chest drain in.
So you have the parameters. Now tell me, this is the patient. It's a real
There is a
life.
stab wound in the chest also. The
Yes.
wound is open.
Hmm.
When he came to ER, the wound was open and you are doing the primary management.
So we said he
So
has a stab in the back, fifth intercostal space on the left side. So
Ma'am,
now
with these parameters, first I would like to stabilize the patient by giving him a fluid challenge. I would like to see whether he's responding or not.
Again, first thing is a fluid challenge. Think again. Please
Ma'am,
revise your answer.
Control of hemorrhage. Sorry, control of hemorrhage.
There is nothing
cannot.
spouting out. There is no spurting bleeding outside.
You cannot control the hemorrhage fast. I said there is an open wound.
Sir gave you the hint.
Ma'am,
See, your
good
answer
check.
will always start that I will follow the
ATLS,
ABCD protocol.
ATLS guidelines.
So I am going to ensure that the patient's airway is patent. As
Proceed.
now, usually see, we work in a team. It is not
Yes,
that
ma'am.
you're alone in the ED. So while
Yes,
you're
ma'am.
assessing the airway, will you ask
ma'am.
your colleague to do something? Sir was talking about the wound repeatedly.
Ma'am,
Three-side dressing.
explore the wound.
Exploration of the wound is not a
ma'am,
priority ever.
No,
Yes,
no,
ma'am.
three-side dressing, ma'am, with one side open.
Yes,
After few,
absolutely.
chest drain will close the fourth
Correct.
side of the.
Absolutely. My camera has gone off, so I cannot appreciate who is giving the answer. But yes, your answer is correct. You will have to give a three-way dressing. And what is the principle?
Yes,
why are we giving a three-way dressing and not just a seal of
Ma'am,
the wound?
it makes a valve, ma'am. It makes a valve for the air to escape out but not come in. So it prevents the occurrence of a tension pneumothorax.
Yes. So there
If
is an
one is not
open wound.
present.
There is no tension pneumothorax. If you cover the wound totally, then you might convert it to a tension pneumothorax. So your friend is doing it. You've assessed the airway. Airway is good. Patient is talking. What next?
And another
ma'am,
term,
then
another term used here is a sucking wound in the chest.
Yes.
What is that?
Open.
Sucking wound in the chest?
Open pneumothorax.
Yes.
So, sucking wound when there is an open pneumothorax and there's the negative pressure in the chest.
So this happens
leads
following
to
a stab
sucking
like
of the
this, or a stab or a penetrating injury. When you have an open in the chest, when the patient takes a breath, what happens?
So there is negative interthoracic pressure which will
So?
suck in the air.
Yes. So through this open wound, air is sucked in during inspiration. The reverse should have happened.
Yes, sir.
Okay.
But so the
So
air
that
is not able to move out.
That aggravates the
Pneumothorax.
pneumothorax. That's the
Yes, sir.
reason that you should immediately occlude this wound on three sides so that whatever
Yes, sir.
air has gone inside should escape through the dressing event.
Yes, sir.
Okay. And then parallelly, yes, your fluid challenge you said is right. You should give the patient oxygen. Saturation is 88%.
Yes, sir.
So what else? Definitive management of this patient.
Ma'am, I
In
would
the
like to
ED.
put in. I would like to put in a chest drain, ma'am, here on the left side in
You
the fifth
want to put in a
intercostal.
chest drain. Where would you like
Yes,
to
sir.
put in the chest drain?
Ma'am, I would like to put it on the left side in the fifth intercostal space in the triangle of safety.
Correct. But unfortunately, this patient has a stab wound there only. So what do? He has a stab on the fifth intercostal
Hello?
space. They have said towards the back, but basically it is through nearly the area of where we put our chest drain through. So what will you do? And your friend has already put a three-way dressing there. So what will you do? Will you take off the dressing and insert the chest tube through that? Or what would you do?
No, I would do it through a separate point, ma'am. Since the fifth intercostal space is involved, I would like to now I would like to move one intercostal space above or below it to put the chest in.
It's a hemothorax. If you go above, will it be rational?
No, sir, below, then
hemothorax.
below, sir.
So
Below,
what is the problem? If you do go there, I mean, he has been stabbed, space is already there. What is the problem if you go in through that space?
Ma'am, because we do not know the depth of the injury, what exact part has been injured, and so ma'am, that wound should not be disturbed. The ICD that we insert will be in a controlled manner in exactly the area that we want to put it.
Don't forget, while you put that chest tube, you have to address this open wound also. Once you take the patient to the theater for putting a chest tube, you cannot ignore this open wound. The open wound has to be managed.
See, there are three very clear points which one should mention. Number one, this is a contaminated wound, right? So you would not want to insert your ICD through that. Number two, an ICD that we put in, it's a very uniform wound so that there is no peri-drain leak. Now this stab wound, existing stab wound, the ICD will never fit in snugly into that, right? So there can always be peri-drain, either leak or suctioning of air. Both of them. Number three, there may be broken pieces of bone or tissue so that if you insert the drain through that point, these broken pieces of bone may be further pushed inside, causing further lung laceration. Right? So these 3 points have to be mentioned. And as sir said, this wound has to be taken care of. You have to, probably subsequently, once the patient has been stabilized, take the patient to theater, debride the wound, close the wound. So those are subsequent steps. But the reason why we don't go in through the same wound are these 3. So if you see in this patient also, this drain was put by my residents yesterday, and it has been perfectly put through the 6th intercostal space, and the position should be posterior-superior. Okay. And this X-ray was subsequent to the putting of the drain. You can appreciate that the extent of the hemothorax has gone down, but there is still obviously a collection which it is going to take some more time. Somebody, one of your friends had said, how will you take care? This is the 3-way dressing that we talk about. And if you appreciate that here we have left one side open so that the inside air will come out. But once the outside air tries to go in, the dressing will stick to the wall and it will not allow the air to go in. Okay. So if this patient, now we have put in a chest drain, initially a gush of blood was there. Now, is there any indication, it's a bad patient, any indication of thoracotomy in this patient?
I mean, this particular patient, there is no indication because the patient has improved.
What are the conditions? See, we are saying that the patient came in that hemodynamic situation. You've applied a 3-way dressing. You put in an ICD. ICD is draining blood. Okay. Now, what 4 indications? Mention 4 indications of thoracotomy in this patient.
More than 1500 ml of blood loss immediately after putting the drain.
Okay.
Or an output of more than 200 ml per 24 hours.
That is called what? That is called as massive bleed. Indicates that the term you are mentioning, if you have this amount of blood on first insertion, that is called as massive bleed.
Massive bleed.
Okay.
Secondly, if
100 ml every 15 minutes.
Pardon, I didn't hear you. Come louder.
Brisk bleeding, bleeding in the chest tube, collection in the chest tube that is 100 ml every 15 minutes.
No, 100 ml 15 minutes is not accurate. See, the indications are, as Milind said, over 1.5 liters ml stat. Stat meaning the moment you put in the drain. It's not 150 ml, it's ICD output of 250 to 300 ml per hour for the next 3 to 4 hours.
3 to 4 hours.
Yeah, this means that there is a continuous bleeding going on. So hemostasis has not been achieved. So you need to take the patient to theater. If you suspect tracheobronchial injury, how will you know that there is a tracheobronchial injury in ED?
Looking at the chest tube and the bag.
Yes, how will you know? You will see large bubbles of air. Pneumo, you see a small drizzle of air. Large bubbles of air coming in. So you will know that there's a tracheobronchial injury. If you suspect esophageal injury, this cannot be identified in the ED. This will be identified only after the CT is done. And you were talking about a diaphragmatic rupture. Yes, if there's a diaphragmatic rupture, again diagnosed on CT. And after putting the chest tube, after a few days, maybe 48 hours, you do a repeat X-ray and you see that somehow the drain is, some parts of the thorax is not being drained. So that means there is a retained pneumothorax. This is an indication where either you may go in for a thoracotomy, but now what they do is more of a VATS, that is a minimally access thoracic surgery. Video-assisted thoracic surgery. Yes, video-assisted thoracic surgery, where the clot might have to be removed because there may be a clot which is not draining. Okay, so these are the indications of the thoracotomy. Okay, so now you had talked about a diaphragmatic rupture. How will you identify a diaphragmatic rupture? Is there any way in the ED where it might make you suspicious that there is a diaphragmatic rupture?
Ma'am, on a plain chest X-ray,
before that,
raised
suppose patient does not have a hemothorax, patient has a blunt trauma chest or trauma in the abdomen, and there is a diaphragmatic rupture. What symptom patient may have before you go to the X-ray?
So he will have a respiratory distress, sir, and there might be bowel sounds heard in the chest thoracic cavity.
Yeah.
Okay, see, Milind, what you said is true. But if you see this patient who has a stab wound, the respiratory distress can be due to other reasons as well.
Yes, ma'am.
So you will not be able to, dogmatically say that it is the respiratory distress is because of diaphragmatic rupture. The hemothorax, the low saturation, these also will give rise to respiratory distress. Okay. And if you do an X-ray, you said bowel sounds in the chest. Now, in an acute setting, you will not be able to get that. These are classical findings in a patient who has an old diaphragmatic rupture. In an acute setting, you will not be able to appreciate any sound in the chest, particularly because there is an associated hemo. So as it is, you're not getting breath sounds. In addition, you will never get bowel sounds. So then you were on the right track as to how you are going to suspect. You can only suspect, you can never be sure. So what are the two features on this X-ray, okay, which will make you suspicious that the patient might be having a diaphragmatic rupture?
Ma'am, one would be a raised hemidiaphragm on the injured side. We would see that, and ma'am, second would be again presence of bowel loops in the thoracic cavity. Yeah,
but if in the background of a hemo, you will not be able to appreciate that.
Raised hemidiaphragm, you see, diaphragmatic injury will not cause raised hemidiaphragm. Try to understand.
Yes, sir.
That is the difference between a eventration of diaphragm and the diaphragmatic rupture. In a rupture, there is a discontinuity of the dome of the diaphragm. Something is going through the rupture. So if you want to trace the dome will not be uniformly elevated.
Yes. So you will not be able to appreciate the dome on that side. That is it. And if you have put a Ryle's tube in the patient, you might see the tip of the Ryle's tube in the thorax, provided the stomach has herniated through the diaphragmatic rupture. If not the stomach, maybe the small intestine or anything else has gone in, then the Ryle's tube will not be visible. Okay. So if the tip of the Ryle's tube is visible, it will tell you that probably there is a diaphragmatic rupture through which the stomach has herniated into the thoracic cavity. Okay. Sir, would you like to add anything to this scenario, sir?
No, it's fine. It's fine.
Okay. So can we move to the third scenario and the third candidate, please?
Yes. Dr. Deepang Gathani, you can take this next scenario.
Okay.
Okay, fine.
Okay. Yeah. Good morning,
Deepang
Dr.
is second year resident at Apollo.
Okay, fine. Okay, Divyang, so first year. Okay, the questions don't change. Okay, so your question
is first year. No, we have. Yes. Okay, then Deepang, we have senior people around. I think who is there? Indrani, come. Dr. Indrani Devnaj is a second year MS PGT at National Medical College, and now she is here at MR Pangur on district residency program.
Okay,
so, Indrani can take the scenario. Okay.
Morning, ma'am.
Indrani, are you ready?
Yes, ma'am.
জোরে বলো।
27 জোরে বলো, শুনতে পাচ্ছি না।
27-year male brought to
Yeah.
emergency after a fall from height. Patient is conscious and gives history of pain in the upper abdomen. Pulse 110, BP 100/70, SpO2 96, respiratory rate 20. Tenderness over right upper quadrant, started on IV fluid.
Okay. So this is your patient. The vitals have been given. Obviously, started on IV fluid was not the first thing. He went through the ATLS protocol. Airway was cleared. Breathing was cleared. And they saw that this is the situation. Though hemodynamically, he seems to be stable. Obviously, given the mechanism of injury that he fell from height, we have to assume that there are multiple traumas. And we have started him on IV fluid. Okay. Now, you have stabilized the patient. The patient, you saw the vitals in this patient.
Yeah. What do you think? The patient is in shock?
Yes, sir. The BP is less. And
So, patient is in mild shock.
Yes, sir.
The classification should be here. The patient should be classified. The patient is in mild shock.
Okay, fine. Now, obviously, once you've stabilized the patient, you are going to ask for certain investigations, right? So what investigation would you like to ask for in this patient?
Ma'am, in this scenario, ma'am, there is a history of fall from height. So probably we will go for E first. Like
you are going to go for E first. So in the primary survey, there are only 2 investigations which you can, 3 actually. You will always ask for a chest X-ray.
Yes, ma'am.
If you take it as a continuity from the previous case, this patient may also be having associated lung injuries, right? Sorry. So you will always ask for a chest X-ray, a pelvic X-ray, and a E-fast, which you said, you were very correctly said, you will do an E-fast. So what is an E-fast, Chandrani?
We will go for USG and
E-fast is USG only, but what do you look for? You
What
said
do you look
E-fast. Fast is one, E-fast is an added part.
yes,
So it is an extended fast, right? Focused abdominal sonography in trauma. So what are you looking at? What are you looking for?
Ma'am, we are looking for the abdominal cavities and pelvic cavities, and associated that with thoracic cavity we can look into.
What are you looking for?
What are you looking for? These cavities are there, but what are you looking for when you're doing a review?
In a normal person,
seeing whether there is any.
We are not measuring liver. We are not measuring spleen. We are not doing especially kidney injuries. We are looking for what? Yes.
So you're looking for
Where?
whether there is any collection.
Where?
And what are the 4 classical areas where we look for? So right upper quadrant, that is a hepatorenal HRPM. Left upper quadrant, you look in the pelvis, and you look in the through the epigastrium at the pericardial cavity. And when you extend it to the thorax, you look at the 2 thoracic cavities to see whether there is any intrapleural collection. So you're looking for either intraperitoneal or interpleural collection. Okay. So yes, you've done a E-fast, and your E-fast says there is fluid in the right upper quadrant and in the pelvis. Lung fields are clear. What next?
E-fast is positive.
E-fast is positive.
Patient is in mild shock.
Fluid in the right upper quadrant and in the pelvis. So what will you do next?
Ma'am, we will resuscitate the patient first.
Yes, you are resuscitating the patient. Anything more? Anything more that you would like to do? Yes, you are resuscitating. You're correct about that. Any more investigations you would like to do? Yes.
E-fast positive while you starting IV fluid, that is a routine for any trauma. While you start IV fluid, you make the channel, what you take up?
We will go for APG.
APG is...
APG, you will do the
APG you can do patient.
Yes. We will go for routine blood examination.
So see, routine, I'm not looking at a hemoglobin TC/DC that side. The emergency, what we need to do is we need to do a blood requisition.
Is important, ma'am, to
what?
Look out for, ma'am, hemoglobin.
Can you come closer to the mic? I cannot hear you, please. Yes, Indrani, what did you say?
Ma'am, we will look for the hemoglobin, ma'am, to look for whether there is any
bleeding. Do you expect hemoglobin to drop if the patient comes within 3-4 hours, even with a background of bleed? Why? Why hemoglobin will not drop at the first encounter? Why hemoglobin?
Sir, Indrani is not audible. Hello? Hello? Hello?
Yes, ma'am,
Yes.
you are audible, but
Can somebody else take over if Indrani is not audible? Can somebody else take over?
The video. The video
Hello?
is cut over.
Hello, yes.
We are logging in again, ma'am.
Indrani is there, or Milind, can you please ask somebody else to take over till Indrani can join back?
Yes, ma'am, I think they've logged in, ma'am.
Okay.
Yes, ma'am, she's logged in.
Yes, Indrani.
Yeah.
Yes, Indrani, we were with you. You wanted to do hemoglobin, and sir said that in an acute setting, you do not expect a fall in the hemoglobin. So a blood parameter is fine to know the baseline for your further management, but in your acute management, the blood parameters are not going to really help. The only thing in a trauma setting that you need to do is blood requisition. Because yes, I agree the patient is hemodynamically stable, but these patients can deteriorate anytime, given the mechanism of injury that he had a fall from height. So at this moment, he has a fast positive and he is a hemodynamically stable patient as of now. Would you like to do any other investigations?
From a blood routine, we will go for CCTA patient. As patient is
louder, please. You want to do a
CT abdomen, ma'am.
So you want to do a CT abdomen of the patient. Okay, I agree with you. So this is the patient. This is also a patient admitted under us at the moment. So this is the CT scan of the patient. The patient was sitting up. Patient was talking to us. Patient was maintaining parameters. IV fluid was on, but he looked very pale. So we had done blood requisition, and this is the CT scan. What do you see in this CT scan? What do you see in the CT scan?
These are axial cuts. Try to read what you see.
Liver is
yes.
Hematoma and
laceration in the liver parenchyma, and ma'am, there is a
so there is a huge area of laceration in the liver parenchyma. What else?
What do you see around the spleen?
Ma'am, there is a perisplenic collection, ma'am.
Not so. This is basically the intraperitoneal, the hemoperitoneum. So there is blood around the. See, if you see here also over the liver. So there is blood around the liver. There is blood around the spleen, and there is a large area of contusion within the liver. Go to the next plate. Here it is even more well defined. Okay. Now looking at this plate in the background of your patient, what is your plan for management of this patient?
So diagnosis is?
Hemoperitoneum.
Hemoperitoneum. Now in this patient, on the background of this injury,
for management?
Okay, I've done a chest X-ray.
Recording in
what
progress.
do you especially look for in the chest X-ray? Which might decide me.
Sir, in this patient, the chest X-ray was within normal limits. There was no evidence of any intrathoracic collection as confirmed by the EFAST also. There were no rib fractures. And the diaphragm.
Free gas on the diaphragm.
No, sir, there wasn't any. I was coming to that. But again, sir, again, Indrani, if there was free gas under the diaphragm, that would have been picked up in the CT also. You would have seen a very black shadow along the rib cage. So there was no free gas under diaphragm, but mind you, the chest X-ray that we did in the trauma immediate setting was not in erect posture. So it might have missed it also, okay? But here, once we did the CT also, there was no evidence of any intraperitoneal air. Given this scenario, what is your plan for management of this patient? So he has a hemoperitoneum, no evidence of pneumoperitoneum, large contusion in the liver with extensive perihepatic and perisplenic collection. What is your plan of management for this patient?
Where will you treat the patient? In the ward or in a critical care unit?
Ma'am, in critical care, we will treat the patient at critical care unit, and we will observe the patient whether there is the shock. The patient is in shock, or if there is further blood loss and there is progressive anemia, then we will go for emergency.
See, we are not
try to understand. This is an injury.
Progressive anemia. This patient at this moment, I had given you the vitals, is not in shock, right? So yes, our point will be, we will monitor the patient in the critical care unit to see whether there is any deterioration of the hemodynamic status. Correct? Are you there with me, Indrani?
Yes, ma'am.
Okay, yeah. So our plan of management for this patient will be a non-operative management. See, given that the CT looks very ugly, there seems to be extensive injuries, right? But if the patient is hemodynamically stable, you will not go in and explore this patient. You will not do a laparotomy. So your plan of management will be, though there is extensive injuries and there is no evidence of a pneumoperitoneum, patient is hemodynamically stable, I will opt for a non-operative management where I will critically observe the patient and monitor his hemodynamics. Now, when do you have to change your plan? You are monitoring the patient. When will you have to change your plan? That no, I cannot monitor him anymore. I need to take him to the theater. When do you have to change your plan?
If the vitals are deteriorating further.
Yes.
And if
vital duty in spite of
as adequate resuscitation.
Yes, you have to keep the patient on maintenance fluid after you have given the fluid challenge.
Okay,
even
and
after
that he's a responder. Then only you can say if the initial fluid is going to be much more. Then once he responds, you have to go into the maintenance mode, right? So he is deteriorating hemodynamically. What else could tell you that I need to take the patient to theater? Anything else?
If there is
as a resident, you will obviously go and clinically see the patient multiple times in the day. So when you palpate his abdomen, are there any features which might tell? Yes.
If, ma'am, there is signs of any peritonitis, any guarding tenderness or rebound tenderness, rigidity is there, then we will also go for emergency operation.
So you are basically saying, I will look for signs of peritonitis.
Yes, ma'am.
Right? Right. Anything else? Anything in the blood counts that might make you think that I might have to change my plan?
If the hemoglobin falls further, then
WBC count raises. Falls, but if it is maintaining hemodynamics, I'll give him blood. Why will I explore him? The hemoglobin falling is what Sir said about some time back, that initially it is not going to manifest. It is going to manifest maybe over the next 24 to 48 hours. So obviously you will get a certain lowering of hemoglobin. But if the patient is maintaining hemodynamics, I'll give him blood. I will not explore him. But yes, peritonitis. And what else? What are the indications of laparotomy in such a case? Okay, since we're running out of time, I'll give it to you. In an hemodynamically abnormal patient, so not this patient. NOM means what? Non-operative management in a hemodynamically stable patient. So in a hemodynamically abnormal patient with suspected abdominal injury, you are going to take him for laparotomy. Intraperitoneal free air. If you see in the imaging that there is you've done a CT, that there is a diaphragmatic rupture, what we were talking about in the previous case. Clinically, first thing, peritonitis. And patient has positive fast, positive on CT, but hemodynamically unstable. That means we had initially a CT, if a CT was done, it means that the patient was stable. An unstable patient would never have gone for CT in the first place. So a CT was done, patient was stable, but maybe next day or 2 days later, you see that the patient's condition has deteriorated. So these are the indications of laparotomy in a patient of blunt abdominal trauma. Okay. Now, having done that, one very basic question. Clinically in the emergency, when you are examining this patient, this sort of a patient, other than the abdomen, Which adjacent areas should be mandatorily examined? Because this is something very commonly missed. Other than the abdomen, which surrounding areas should be mandatorily examined?
Ma'am, thorax.
No, a thorax is separate, adjacent to abdomen. You have to mandatorily examine the pelvis, because there may be an associated pelvic fracture, which might give to the positive fast in the pelvis. Do not forget to examine the perineum and the genitalia. We had a patient where the perineum was missed. We went in for non-operative management. 2 days into it, then the patient was not looking good. His counts were rising. And then we realized we had missed a rectal injury. So ultimately, we had to go in and do a stoma for this patient. So do not forget to examine the genitalia and the perineum of the patient, irrespective of the gender of the patient. Okay, there may be associated injuries. Fine. So this patient was treated non-operatively. Now our CT scan also said that there is a vascular blush in the CT. Vascular blush reported on the CT. That cut is not there in this image. So what is your thought? Why is there a vascular blush in the region of the liver? What will that mean?
Vascular blush means what? There is extravasation of contrast. What does it indicate?
Bleed from the blood. There is an injury to the
So
blood.
there is active bleed.
Active bleeding.
If a vascular blush in CT scan, that indicates there is active bleed in the injured site. So patient is bleeding. What do you expect?
So now what are your options of management? Patient is maintaining hemodynamics, but CT says there is a vascular blush. What are your options of management?
Angioembolization.
Louder, please.
Angioembolization.
Yes, you might go in for an angioembolization. Again, point to be remembered, angioembolization can only be done in a hemodynamically stable patient. If you see a vascular blush and your patient is deteriorating, this is an indication where you have to take the patient to theatre. And another very relevant point is that angioembolization facility may not be available in all institutes. So you have to be very alert about it. So this same patient, after 5 days, he starts developing a mild abdominal distension. After 5 days, mind you, the count is increasing. Patient is developing icterus. A USG was done, which revealed a collection in the right hypochondrium and pelvis. How would you like to proceed in this case? Indrani?
Bleeding probably has stopped.
Yes.
Patient is immediately stable, bleeding probably has stopped. Now you are finding there is a good amount of collection, perihepatic and also in the pelvis. And patient is having fever, high count.
The patient might have a biliary leak due to a biliary tract injury.
So what would you like to do, Milind?
Indrani,
please.
Drainage, ma'am.
How? You will take the patient to OT again or what?
We can put a drain locally by PTC or pictal drainage or
absolutely
drainage.
Correct. So yes, you will confirm and you might put a pigtail in the collection. Okay. Now, so you have put a pigtail and you're getting bile in the pigtail. Anything else you would like to do? Just a pigtail is good enough to, as a source control, the collection is drained, possibly the count will come down. But anything else you think will be required?
Actually, is draining maybe 300, 200. So
anything else may be required? See, if there is a bile leakage, means there has to be a source. It may be from the liver bed. It may be that some part of the biliary tree has been injured. So you have to do an ERCP, assess the biliary tree. An MRCP may be given, but mind you, it's not very useful in the background of a collection because it is going to obliterate your vision, the collection. Otherwise, you will do an ERCP. You might have to stent the biliary trees to decompress it. Then only the leakage of bile is going to stop. So if it is a bile collection, yes, a pigtail first, or if you do not have a pigtail, a smaller drain, as you correctly said, and then you have to do an ERCP and stenting. So the point that I was to drive to you is, remember, non-operative does not mean just not operating. There are many adjuncts to non-operative, and angiography with embolization, and ERCP with stenting, a percutaneous drainage. These are all part of non-operative management. So we do not operate on a patient doesn't mean we do not do anything else. So it is a very highly responsible job if you decide to go for a non-operative management, because you will, number one, have to critically monitor the patient multiple times, and if necessary, any of these may be necessary. Okay, fine. Sir, shall we move to the next scenario?
No. We'll take another class. We'll have another session. Okay, my 9-5 people are going from the duties. One thing is, suppose you have explored the patient and you find that there is active bleeding from this injured site. You are in the abdomen. What are the steps to control that bleed?
Packing.
So we will do packing.
Perihepatic packing, Pringle aneurysm.
You are a senior emergency surgeon. So just bleeding and packing and coming out means you have to go again. What all you can do? There is a bleed from the surface laceration. You have done
what
Pringle.
Are the options?
You have done Pringle. The bleeding is not stopping. What does it mean? You have done Pringle. The bleeding is stopping.
Hepatic.
So if you are having a good Pringle and still bleeding, that indicates it's not bleeding from the portal vein or the hepatic artery territory. It is bleeding from the hepatic vein side. So you have to now think of whether there is further injury.
IVC.
Or IVC. Okay. So when you first explore and find there's a bleed, you need to debride the devitalized tissue. And then you find the bleed, you can control. In major laceration, patient is hypotensive, you cannot spend time. In that case, the damage control surgery. That means you pack. And when you pack, suppose there is a cavity, which is a practical question. Where do you place the pack? What is that called as? The particular term used is, will you pack the cavity?
It's called perihepatic packing.
Yes.
That means the idea is that we bring the pieces of liver parenchyma close together. If you put a pack in between, means you're keeping them away, thereby, encouraging more bleed. So you bring the torn pieces closer and you do what is called a perihepatic packing. And then you might just, temporarily close the abdomen, shift the patient to ICU, and then monitor it. Here is where an ABG is very important. So you have to see whether the lactate levels are going up or down, count is rising or not. Take the patient back to OT 24 to 48 hours when the patient is hemodynamically and metabolically improved. The acidosis has to go down. Otherwise, if you take the patient, he is going to die on table. So yes, once you have stabilized the patient, you may take the patient back to OT, remove the packs, observe. If any further, procedure requires to be done, you can do it. And then, the closure is a temporary closure in these cases.
And keep in mind the grades.
Yes, I just put this as a slide. You must know
how
the
you
grades.
grade your injuries.
Yeah. So this is the AAST grading. In this patient whose CT I shared with you, it was a grade 4 liver injury. So if you just look at the report, they will say grade 4 liver injury, and you will jump to the conclusion thinking that this patient is severely injured, I need to operate. But mind you, it is monitoring of the hemodynamics, which is of the utmost importance. Okay, sir, shall we stop then, sir?
Okay, madam, yes. We'll take another class from maybe then next to next month. Next month,
okay, so
program
maybe
is made.
3 or 4 more scenarios, then
yes,
we
yes,
can
yes.
have discussion.
Yes,
okay.
3 or 4 more. Yes, it's good. These are the typical OSCE scenario, more important for DNB students, I agree. But I think MS student also may have some OSCE scenario coming up. These are basically ward round scenarios.
Ward round scenarios, yes, sir. Yeah. Okay, sir.
Thank you. Thank you.
Thank you, sir. Thank you.
So, leave.